In this lecture, we will continue with the rest of the glomerulonephritis. So before we proceed with the rest of the glomerulonephritis, let's discuss a clinical case. An 8-year-old child was brought by the mother to the hospital with chief complaints of puffiness of face, which was more noticeable in the morning, along with swelling of both legs and passage of smoky urine. The patient was recently treated for a throat infection. On examination, there was pallor and pedal edema. Blood pressure was 150 by 110 millimeter of Hg. Pulse rate was 90 per minute, respiratory rate 22 per minute. On systemic examination, no abnormality was detected in respiratory system, abdomen, CVS or CNS. So based on these clinical findings and this history, what is your possible diagnosis? What are the investigations that you would like to do to confirm your diagnosis? And if at all you order a renal biopsy, then what are the likely findings on renal biopsy? On light microscopy, on immunofluorescence and electron microscopy. The answers to all these questions I would want you to submit along with the other exercises that I will post after the end of this lecture. So with this, let's start with the rest of the glomerulonephritis. So continuing further on, we have focal segmental glomerulosclerosis or simply FSGS. This is the most common cause of nephrotic syndrome is in adults as compared to minimal change disease, which is the most common cause of nephrotic syndrome in children. So as you can see, it has two terms. It is focal and it is segmental glomerulosclerosis. So there is sclerosis and hyalinosis of glomeruli, which is focal and segmental in distribution. So these two terms, this focal lesions and segmental lesions, they go side by side in FSGS. So what do they actually mean? Focal lesions, when we talk about, it has to do with the number of glomeruli. That is, out of say 10 glomeruli, how many glomeruli they are affected. And segmental lesions are when we talk about an individual glomerulus, and segment meaning a segment of glomerulus or a part of glomerulus is involved. So in FSGS, glomeruli, they will have focal lesions, and focal lesions also will have segmental distribution. So repeating it once again, focal lesions, they have some of the glomeruli, they will be involved. For example, if we are seeing 10 glomeruli in a biopsy, so out of them 4 will be involved, and it needs to be differentiated from diffuse glomerulosclerosis. Diffuse is cutoff for focal and diffuse is 50%. If we are seeing 10 glomeruli, so if less than 50% are involved, then it becomes focal lesion. If more than 50% are involved, then it becomes diffuse lesion. Other term is segmental lesion, where a part of glomerulus will be involved, and the opposite term of it would be global lesions, where whole of the glomerulus it will be involved. So there are focal lesions or diffuse lesions when we talk about number of glomeruli, and there are segmental lesions or global lesions when we talk about a part of glomerulus. So in FSGS, there will be involvement of less than 50% of the glomeruli, that is, there will be focal involvement, and these glomeruli they are involved segmentally, and rest of the glomeruli they will be normal on light microscopy. So coming on to etiopathogenesis, it can be primary or idiopathic, which accounts for the majority of the cases of FSGS, or it can be secondary, like it can be associated with conditions like heroin abuse, HIV infection, then secondary event in other type of glomerulonephritis where it was a minimal change disease or IgA nephropathy to begin with, and then it later on progresses into FSGS. Then it can be as an inherited form, like mutation of podocin gene is the gene involved in inherited type of FSGS. You would recall that nephrin gene is involved in inherited type of minimal change disease. Then finally, it can develop in the setting of renal ablation diseases. Here, it is developing secondary to loss of renal tissue, which can be due to a number of conditions like reflux nephropathy or unilateral agenesis. There, the remaining renal tissue, it also undergoes secondary type of FSGS. This is a diagrammatic representation of glomerular slit diaphragm. In the center, we can see nephrin molecule, which was responsible in inherited or finished type of minimal change disease. And just inside the cell membrane, we have this podosin gene or podosin protein, which is responsible for inherited type of FSGS. Coming on to pathogenesis of FSGS, it is unknown. Some say, or some are of the opinion that it is because of transformation of some uh, type of minimal change disease. A subset of minimal change disease patients, they go on to progress into FSGS, whereas others are of the opinion that FSGS and MCD or minimal change disease, they are different from the outset. But the initiating event which is agreed upon is that there is injury to podocytes due to some circulating chemical mediator. And this leads to increased permeability and deposition of hyaline proteins, and areas of damaged glomerulus, they undergo sclerosis. Morphology. On light microscopy, there will be presence of focal and segmental lesion, that is, some of the glomeruli will be involved and a part of the glomerulus they will be involved. Then lesions, there will be increased mesangial matrix, there will be obliterated capillary lumina, sclerosis and hyalinosis. Then on immunofluorescence, there will be presence of IgM and C3 deposits, and on electron microscopy, there will be effacement of podocyte foot processes. Now this needs to be differentiated from minimal change disease, where again we had effacement of podocytes. But minimal change disease, it has normal morphology on light microscopy, as well as there is no presence of any kind of deposits on immunofluorescence or electron microscopy, whereas FSGS has its characteristic focal segmental lesions and presence of IgM and C3 deposits. Clinical features, it has non-selective type of proteinuria. As you would recall that in minimal change disease we had highly selective kind of proteinuria, and it is usually in nephrotic range. So FSGS has non-selective proteinuria, and it has poor response to steroids as compared to our minimal change disease, which has a very good response to steroids, and it can affect the transplanted kidney as well. This photomicrograph shows a glomerulus involved by FSGS. So if you're talking about this single glomerulus, so here we can talk about only segmental lesion. So as you can see that upper left half of this glomerulus, it is more eosinophilic, and it is uh, converted into a jumbled up mass, and the capillary lumina, they can also not be well delineated as compared to the right lower half, where they are easily discernible. So the upper left half, it has become completely converted into this bright eosinophilic sclerotic lesion. Then just a word about HIVAN or HIV associated nephropathy. This is a severe form of collapsing variant of FSGS observed in HIV patients. So this occurs in 5 to 10% of HIV positive patients, and the renal lesions, they comprise of a collapsing type of FSGS where the glomerular capillary loops, they are completely collapsed. Then there is cystic dilatation of tubular segments which are filled with proteinaceous material. Also there is peritubular inflammation and fibrosis, and endothelium, they show the characteristic tubulo-reticular inclusions on electron microscopy. Now these changes, these are probably due to infection of glomerulus and tubular cells by HIV. So basically, HIVAN is where we have this collapsing type of severe form of FSGS, and there are tubular lesions in the form of cystic dilatation of tubular segments, and which are filled with this proteinaceous material along with peritubular fibrosis. This photomicrograph is of HIV-associated nephropathy, or which is also called as collapsing glomerulosclerosis because of collapse of glomerular duct. So you can see we have these three glomeruli here in this field, and at least two of them, they are completely collapsed, so that the urinary space or the Bowman space, it is markedly enlarged, and the tubules, they are dilated and they are filled with this proteinaceous eosinophilic material. Coming on to the next entity, which is membranoproliferative glomerulonephritis, or which is also known by the name of mesangiocapillary glomerulonephritis. So as you can see, this is a combination of two terms, membranoproliferative or mesangiocapillary. Both give equal information. Membrano means there is involvement of membranes, and proliferative, that is there will be proliferation of mesangial cells. Similarly, mesangiocapillary also tells about that there will be involvement of glomerular capillaries, and there will be involvement of mesangium. So it is characterized histologically by membranous alterations which are combined with glomerular cell proliferation and leukocyte infiltration. So there are two components. And one of the important causes of nephrotic syndrome is this membranoproliferative or mesangiocapillary glomerulonephritis. Coming on to etiopathogenesis. It has again primary and secondary types. Primary can be type 1 or type 2, which is also called as dense deposit disease. Then secondary, secondary is usually similar to type 1 morphologically, and it has causes like chronic immune complex disorders like SLE, hepatitis B, hepatitis C virus or HIV, or alpha 1 antitrypsin deficiency. Then malignant diseases like CLL and hereditary deficiencies of complement regulatory proteins. So this is the etiopathogenesis. It has two types, primary and secondary. Uh, Primary type 1 and secondary, they have similar morphology, whereas type 2, it is a specific entity and it is called as dense deposit disease. Starting with pathogenesis, type 1 has immune complex deposition and activation of both pathways of complement system. In primary membranoproliferative glomerulonephritis, the antigens, they are unknown, whereas in secondary MPGN, the antigens, they can be of various types like HBV, HCV or HIV. Basically these are planted antigens. Fundamental defect is immune complex deposition. So these two, as we had discussed earlier also, that type 1 and secondary type of MPGN, they will have similar morphology. Whereas in primary type 2 or dense deposit disease, this has a different pathogenetic mechanism. So let's discuss this. This is because of abnormalities of alternate complement pathway. Here there is decreased C3 levels and normal C1 and C4. That meaning the classical pathway of complement, it is intact. So C3 and properdine, they are deposited with absence of IgG in cases with dense deposit disease, and this has been observed that more than 70% patients with dense deposit disease, they have circulating antibody which is termed C3 nephritic factor. And what does this C3 nephritic factor does? This binds C3 convertase and stabilizes this and activating excess of complement, mainly the alternate complement pathway. So the fundamental defect in dense deposit disease is excess complement activation, and that too of alternate complement pathway, because of presence of this circulating antibody which is called as C3 nephritic factor, which binds to C3 convertase and stabilizes it and activating the complement cascade. Starting with morphology, on light microscopy, all these three, type 1, dense deposit disease, and secondary type, they have similar appearance. So it has two components, membranoproliferative. So starting with membranous component, there will be thickening and duplication of glomerular basement membrane due to immune complex deposition, which gives rise to tram track appearance, and this is better appreciated on periodic acid shift stain. Then proliferative component, the glomeruli, they become large and hypercellular. This hypercellularity is contributed by mesangial proliferation as well as endocapillary proliferation. This endocapillary has two components, capillary endothelium and leukocytes. So because of this glomeruli, they have accentuated lobular appearance, and in severe cases we can also observe crescents. So two components are there, membranous component where there is thickening and duplication of GBM leading to this tram track appearance, and there is a proliferative component where there is glomerular hypercellularity and there is accentuated lobular appearance because of proliferation of mesangial cells, capillary endothelial cells and leukocytes. On immunofluorescence, we have slightly different appearance. Type 1 membranoproliferative glomerulonephritis along with secondary type, they have discrete subendothelial and mesangial deposits. So I have highlighted this subendothelial because till now all the forms of glomerulonephritis where we discussed about deposition of immune complexes, almost all of them they were on subepithelial side. So this is the only one which has subendothelial deposits along with mesangial deposits, and these deposits they comprise of IgG, C3, C1 and C4. So both pathways of complement they are involved, classical pathway also and alternate pathway. Whereas type 2 membranoproliferative glomerulonephritis or simply dense deposit disease, it has presence of only C3 on either sides of glomerular basement membrane, and IgG is conspicuously absent. So here there is involvement of only alternate pathway of complement. So these are the differentiating features of type 1 MPGN along with secondary type of MPGN vis-a-vis type 2 MPGN on immunofluorescence. This photomicrograph shows the involvement of a glomerulus in a case with membranoproliferative glomerulonephritis. You can see that the segments of glomerulus they have become accentuated, giving the glomerulus a lobular appearance. Also, the size of the glomerulus it is enlarged and it is hypercellular. However, the glomerular basement membrane duplication or thickening is not well appreciated in this diagram. Continuing with electron microscopy appearance, type 1 MPGN has subendothelial electron dense deposits. Mesangial and subepithelial deposits may be there, but the characteristic deposits are subendothelial deposits. Then type 2 has lamina densa of the glomerular basement membrane. It is converted into a thick electron dense structure, and this is due to deposition of dense material of unknown composition, and that is why the name dense deposit disease, because there is deposition of a electron dense material on lamina densa of glomerular basement membrane, and these deposits they are intramembranous deposits, so they will also give the appearance of a duplication of glomerular basement membrane, where actually it's not duplicated but it is because of the deposition of this type of electron dense material in the center of glomerular basement membrane. Then clinical features, usually it affects young adults. It presents with combined nephrotic and nephritic syndrome, and if the patients they have crescents, then they will clinically develop into or present as RPGN. Then almost 50% of these patients they will progress to chronic renal failure and chronic glomerulonephritis, and it does not respond well to steroids, and it can also involve the transplanted kidney just like focal segmental glomerulosclerosis. This is a diagrammatic representation of two types of MPGN. On the left, we have type 1 where you can see these black colored subendothelial deposits. So subendothelial deposits will lie between the endothelial cells of glomerular capillary loops and glomerular basement membrane. On the right, we have dense deposit disease where we can see that this black colored substance is lying within the matter of glomerular basement membrane, particularly in the lamina densa region. Then coming on to the next entity, which is IgA nephropathy, also known by the name of Berger disease. This is characterized by presence of IgA deposits in mesangial regions and which are detectable on immunofluorescence microscopy. Although this disease can be suspected on light microscopy because of some mesangial prominence, but diagnosis or definite diagnosis can be made only on immunocytochemical techniques where these IgA deposits, these are demonstrated with the help of anti-IgA antibodies. Typical presentation would be of gross or microscopic hematuria, and it is one of the causes of isolated urinary abnormality. At times, nephrotic syndrome or RPGN they can also develop in these patients. Probably this is the most common type of glomerulonephritis worldwide. So this is important, IgA, and along with that we have minimal change disease, which is the most common cause of nephrotic syndrome in children, and we have FSGS, which is the most common cause of nephrotic syndrome in adults, and along with that we have nephritic syndrome, where the most common cause we have post-streptococcal glomerulonephritis. So this has been linked with Henoch-Schönlein purpura. There are two subsets or variants of it. If it is limited only to the kidneys, that is the deposits of IgA, they are being seen mainly in the kidneys, then it becomes IgA nephropathy. And if the deposits of IgA they are systemic, then it is called as Henoch-Schönlein purpura. Coming on to pathogenesis, two hypotheses they are there. The more widely accepted one is that in response to some environmental agents there is increased production of IgA. Now these IgA along with anti-IgA antibodies, they are trapped in the kidney and they become deposited in the mesangium, and where they activate alternate pathway of complement and initiate glomerular injury. So this is one mechanism where excess of IgA they are produced and against them antibodies are formed, and these immune complexes of IgA and anti-IgA antibodies they become trapped in mesangium and ultimately activate the alternate pathway of complement and cause glomerular injury. The second hypothesis is that there is some kind of structural change in IgA, and because of that it becomes immunogenic, and that leads to generation of anti-IgA antibodies. Now these IgA and anti-IgA immune complexes they then become deposited in the mesangium and ultimately activating alternate pathway of complement and initiating glomerular injury. This photomicrograph is of glomerulus involved with IgA nephropathy. We can see that glomerulus, the mesangium, it is very prominent. It is bright eosinophilic, whereas the rest of the glomerulus is normal. And this prominent mesangium, it is also pointed by these yellow colored arrows at multiple places. This photomicrograph is of immunofluorescence in a case with IgA nephropathy, as we had discussed earlier also, that for definite diagnosis of IgA nephropathy, we need demonstration of these deposition of IgA on immunofluorescence. So here we can see this characteristic immunofluorescence deposition of IgA uh, principally in the mesangial regions. So with this, we have covered different types of primary glomerulonephritis. Now coming on to chronic glomerulonephritis. Uh, these are a pool of end-stage glomerular diseases which occur as an end result of various types of glomerulonephritis. Most of the glomerulonephritis that we had discussed, they were acute glomerulonephritis. A subset of these glomerulonephritis with varying percentage or incidences, they can go on to convert into chronic glomerulonephritis, where they become long-standing disease, ultimately resulting in loss of sufficient amount of renal function and end-stage kidney. So what are the different glomerulonephritis that contribute towards development of chronic glomerulonephritis and in turn resulting in end-stage kidney disease. 1 to 2% of post-streptococcal glomerulonephritis, they can go on to become chronic glomerulonephritis, so it has kind of good prognosis. Then 90% of patients with crescentic glomerulonephritis, they will go on to progress into chronic glomerulonephritis. So fairly bleak prognosis in these patients. Then 30 to 50% of patients with membranous glomerulonephritis, 20 to 50% of FSGS cases, 50% of membranoproliferative glomerulonephritis, and 30 to 50% of IgA nephropathy cases, they can go on to become chronic glomerulonephritis. Coming on to morphology of chronic glomerulonephritis, grossly the kidneys, they are small and they can weigh as low as 50 grams, and these are symmetrically contracted, meaning both the kidneys, they will be almost similarly contracted, and there will be presence of a diffusely granular outer surface of kidney, and this needs to be compared from irregularly contracted kidney of chronic pyelonephritis. So these are two terms, one is glomerulonephritis and the other one is pyelonephritis. We have a separate lecture on pyelonephritis. For now we will be limiting ourselves to glomerulonephritis, where we have these symmetrically contracted diffusely granular kidneys. On cut section, the cortex will be thinned out with increase in peripelvic fat. Cortex will be thinned out because of loss of sufficient amount of renal tissue. Then coming on to microscopy, it depends upon the stage of the disease. Glomeruli, in early stages, glomeruli can show some features of which can give you hint about what was the primary type of glomerulonephritis that has led to this chronic glomerulonephritis, or if it is fairly advanced, then there can be complete obliteration of glomeruli and we cannot differentiate what led to this type of chronic glomerulonephritis. Then tubules, they will show marked atrophy. Interstitium will show changes like fibrosis, mononuclear inflammatory infiltrate. And vessels will also be involved. Arteries and arteriolar obliteration will be there, and this will be because of accompanying hypertension because glomeruli are involved. So as you can see that all the components, although the primary site of affliction was in the glomeruli, but because everything is interdependent, so ultimately glomeruli, tubules, interstitium as well as the vessels, they all will show changes in chronic glomerulonephritis. Then many of these patients, they will require dialysis as life support. So there can be changes induced because of dialysis also. So there can be arterial intimal thickening, or there can be presence of various type of crystals like calcium oxalate or urate crystals in the tubules, and they can be, as you would recall, dialysis is also one of the causes of acquired cyst formations. So cysts can also be seen. And finally, in a small subset of patients, adenomas and adenocarcinomas, they can also develop. Then clinical features. So this type of chronic glomerulonephritis, it develops slowly and it progresses to renal insufficiency and death from uremia if not a life support is not provided to these patients in the form of dialysis. Also, these patients will have edema, hypertension, anemia, electrolyte imbalance, cerebral and cardiovascular diseases. All these will be because of loss of normal renal function. Treatment is lifelong dialysis or if a renal transplant is available for these patients. So chronic glomerulonephritis, these are basically not a single entity but a group of various kinds of acute glomerulonephritis which will develop into this chronic kind of condition, and ultimately it will lead to sufficient amount of renal tissue which is lost and leads to renal failure, and then all these morphological changes they are seen. This is a gross picture of a case with chronic glomerulonephritis. As you can see that both the kidneys, they are symmetrically contracted and they are regularly contracted. There is no Irregular contraction, meaning the shape, the reniform shape of the kidneys, it is well maintained, and the surface, it has a granular appearance. This photomicrograph shows features of chronic glomerulonephritis on microscopy. This preparation is Mason trichrome stain, which is used to highlight connective tissue components. So in the center we have this normal glomerulus, which is highlighted by this black colored star, and all the rest of the glomeruli, some of which are highlighted here by these yellow colored stars. These are completely obliterated or sclerosed, and they have become completely blue because of presence of collagen. Then also in the interstitium we can see these blue colored small dots. These are chronic inflammatory cells comprising of lymphocytes and monocytes. The tubules, we can also see they have become, their lining has become flattened, so they are atrophic. Also in the right lower corner there is a vessel pointed out by this yellow colored arrow, and you can see that the wall of it is also thickened. So all the components of the kidney, glomeruli, tubules, interstitium and vessels, they all are involved in a case with chronic glomerulonephritis. This is a line diagram of a case with chronic glomerulonephritis showing end stage kidney. The glomeruli, you can see they have become completely acellular, converted into a bright eosinophilic jumbled up mass, and these have become completely hyalinized. Then similarly in the interstitium we can see fibrosis and clusters of mononuclear inflammatory cells. Also a vessel is also pointed out here in the left upper corner, where it has its wall, it has become thickened. Similarly, the tubules, they have become atrophied, they have decreased in size, and their lining is also flattened out. So with this we complete the acute glomerulonephritis as well as chronic glomerulonephritis. In the next lecture we will discuss about tubulointerstitial diseases of kidney.